Subdural hematoma is the topic, and the best way to start is by drawing a diagram to describe all the layers. So you have the brain, and right on top of the brain sits a layer called a pia mater, and above that there's a little bit of space, and then you have another second layer, and that is known as the arachnoid matter. And then above that there's a little bit of space, and then you have a third layer, which is the topmost layer, known as the dura mater. And above the dura mater, directly above it, is the skull. As you can deduce, subdural hematoma is a collection of blood beneath the dura, so it would be this area right here. And this can be easily seen on a CT scan. We'll talk a little bit more about that later. So what's exactly happening, and why does this happen? The etiology, why would somebody develop a subdural hematoma? Well, there's several reasons, but I'll break it down into three categories. We'll talk about infants, we'll talk about the elderly, and then we'll talk about alcoholics. And each of these categories has a reason for developing this bleed, intracranial bleed. So infants, unfortunately, one of the causes is physical abuse. It's quite tragic, and children can develop this, and this can be a consequence of basically the child being hit or maybe shaken very violently. Elderly actually develop this because as a person ages, especially above the age of 60, their brain starts to atrophy. And when there is brain atrophy, there are these veins that exist in the dura. They're called bridging veins. And these bridging veins, what happens is, as the brain atrophies, these veins can easily be stretched. And this stretching can eventually cause rupture. And that rupture is essentially what is responsible for producing this subdural hematoma, this intracranial bleed. And that's very, very important. That's very commonly tested. Alcoholics, next one. Well, alcoholics, unfortunately, because they have this very poor nutrition, and alcohol misuse leads to a lot of problems, they can have prolonged bleeding times, and that can lead to this tragic or disastrous effect. Alcoholics also can have brain atrophy, which is interesting, and that cerebral atrophy can lead to tension on the bridging veins in the same way as the elderly. There's one other category I wanted to talk about, that is people on any kind of anticoagulation treatment. So for example, patients that are on warfarin. People that are on this type of treatment can have bleeds, and that's a very important thing to watch out for. So the most important thing that you'll see on clinical vignettes is, how does the patient present? So usually the chronology is there's some sort of head injury. Now of course, there doesn't always have to be, but usually there is some sort of head injury, maybe a fall or maybe an accident, something like that. And usually they're talking about someone elderly. In most clinical vignettes, and it's an elderly patient. And then what happens in the acute phase is that the patient is relatively normal. There's absolutely no symptoms whatsoever. But then about 2 to 3 weeks later, when sometimes the patient has even forgotten that this initial traumatic event happened, there is a gradual decline in neurologic function, gradual neurologic deficit. And that is a very classic presentation. And what do we mean by neurologic deficit? Well, the patient will have increased confusion, the patient will have maybe some personality changes, drowsiness, and clearly there's something wrong with the patient, and the patient is then brought in to the emergency room. Headache also can be present. Now, very quickly on physical exam, what you want to see, or look for rather, are signs of increased intracranial pressure, because the bleed is building up in that subdural space. And signs of intracranial pressure, of course, you check the eyes for papilloedema. And in babies, in infants, or children that are under the age of 1, you can see bulging of the anterior fontanelles. So those fontanelles that are normally not supposed to be bulging will be so, and that's a sign of intracranial pressure being increased. So how do you diagnose this? Well, imaging, of course, CT scan, without a doubt. The CBC can probably also be done. Liver function tests are helpful in alcoholics, but without a doubt an imaging test as quickly as possible once you have a suspicion of a subdural or any kind of intracranial bleed. Treatment. Now this is one of those emergency treatments, and it's a neurosurgical treatment. A neurosurgeon will be the one involved in doing emergent craniotomy and draining the blood. The blood is evacuated. And one final point I wanted to mention before I get to the clinical vignettes is very important about prevention. One of the biggest reasons this happens is falls in the elderly. And therefore, one of the biggest aspects of prevention of this is making sure the home environment is safe, and that there's nothing that they would trip or fall, because if they do, the result can be quite devastating. So let's take a look at some vignettes, see what this looks like. 71-year-old man, excellent health, practicing competently as an attorney. He's brought to the emergency room following a motor vehicle accident. A workup including imaging of the spine, thorax, and head is negative, but the patient is admitted for overnight observation. His injuries include several lacerations to the face and extremities, as well as several contusions to the thorax. 3 weeks later, he is admitted to the hospital for confusion. A neurologic exam is normal, except he is not oriented to time or place. He can only recall 1 out of 6 objects after 3 minutes. Which of the following is most likely diagnosis? Well, classic history, presentation of subdural hematoma. As you can see, there was an initial event. He was okay, but then 3 weeks later, he shows up with this neurologic defect presentation, decreasing mental status, and obviously that results in him having to come to the emergency room. So the answer is subdural hematoma. Next question. 77-year-old man becomes senile over a period of 3 to 4 weeks. He used to be active and managed all of his financial affairs. Now he stares at the wall, barely talks, and sleeps most of the day. His daughter recalls that he fell from a horse about a week before the mental status changes began. Which of the following is the most likely source of the bleeding? Well, again, classic. There was some sort of a traumatic event, blunt trauma to the head most likely, and he was okay. And then later, as it says here, 3 to 4 weeks later, he develops this gradual deterioration of a neurologic status. And then they're asking, where is the bleeding occurring? Well, in that dura area, you have these bridging veins, and they can rupture and lead to a subdural hematoma. And then finally, an 82-year-old man is admitted to the hospital after he started dragging his right leg today. Workers at the nursing home where he resides also noticed that he was not as talkative as usual. His temperature is 98. His speech pattern is non-fluent. On the right side, hip flexion, knee flexion, dorsiflexion, abductor, hallucis longus were weaker than other lower extremity muscles. Cell counts, chemistries, and coagulations are normal. CT scan of the head shows a 1.5 centimeter left-sided subdural hematoma. His granddaughter arrives after he returns home from the CT scan and is very concerned about her grandfather's condition. Most appropriate next step is, Well, this is a neurologic or neurosurgical emergency, and a neurosurgical emergency involves a immediate craniotomy with evacuation of that blood, and that can only be done by a neurosurgeon. So that would be choice B.